Hello, good afternoon, everyone. My name is Chris Urbanek. I'm a Regenexx physician in Des Moines. Thank you for joining us for our lunchtime webinar. Let me share the screen and we will start talking about our topic for the day. Okay, so today we're going to really be talking about neck pain and kind of some of the implications for, what the pain, where it goes, what it's causing from, and kind of what we can do to treat it and get some of the symptoms under control. We'll talk a little bit about some headaches as well and kind of their relationship to the neck pain. So as we kind of take a first look here, I really want to just go over some basic anatomy. So the image on the left is skull and neck bones. We can see a little bit of the rib cage down below it, and we're looking from the back to the front. The image on the right is basically looking at the side of the exact same thing. So you can see the skull, the jaw, and then the bones that make up the neck before we get to the rib cage area. And so this kind of just shows us our bony alignment, and there's far more structures than that, but we want to have a good starting point of understanding the anatomy so that as we talk about treatment and pathology, we kind of can see where some of this is coming from. So we number our vertebrae from top down. And so the first cervical vertebrae under the base of the skull is our C1. And then there's a joint kind of between each of these. So between the base of the skull and the first vertebrae, there's a joint. Between the first vertebrae and the second, there's a joint, and that goes on all the way down. Now, when we talk about cervical discs, because many people will talk about intervertebral disc injury, those don't really start until you get to the space between the second and the third vertebrae. That's our first cervical disc. And then those continue the rest of the way down through the spine until you get to the sacrum. And so the joints themselves, we call facets. In the lateral view here, you can see they almost look like shingles kind of overlapping each other, just like on a roof. And so these are the joints on the posterior side of the neck that give us our posterior support. The disc is what gives us some support on the anterior side. And then between each of these kind of sticky outy bits on the back are a series of ligaments that kind of stabilize this whole area. Essentially, it prevents forward bending. And so these are important players in the game as well. You may have an issue where you've been told, yes, you have a disc injury. But one of the things that we commonly see with disc injury is overpressuring the anterior side or the front side of the system because these ligaments in the back have gotten loose. They've allowed the weight to be shifted more forward. And that's something that we see just a lot in our daily lives. A lot of us are sitting at a computer or looking down at a screen or our cell phones, and that puts a kind of a passive long-term stretch on these ligaments that makes them not do their job quite as well. So by getting these guys stronger, we can actually treat some of the issues with the disc, and we'll certainly talk about that a little bit more as well. So seeing some of the raw anatomy, now we have basically a schematic here that's showing essentially the same thing, and we're going to talk about how different pathology can affect these discs. So the blue squares are the vertebral bodies. These are the areas that sit on either side of the disc, kind of like an Oreo cookie. And in this picture, the disc is this gray block. The spinal cord is what's running in yellow just behind it. And then as we kind of saw those sticky outy bits on the anatomy picture, that's what this process is back here. This is essentially our spinous process, and where they overlap is the facet or the joint. So at each of these levels, there's a small gap where our nerves come out. And as we're talking about the cervical spine, these are our nerves that go to our arm, our forearm, hand, and fingers. And it can be affected by things that happen to the disc. So we see certain types of disc injuries here. And so we'll just go left to right. On the left, this is a disc herniation in which kind of the content, which is gel-like, will move posteriorly. And it can either physically impinge on the nerve, so it creates a mechanical effect, or what's really more common is it creates a chemical effect. It's a highly irritant substance, and so the nerve becomes quite agitated. Another type of disc injury is the bulge, where from either increased pressure or injury to the ligaments that support the disc, we see it just kind of pushes its whole self backwards, and it may favor one side versus the other. It creates kind of more of that mechanical effect of actually pushing on the nerve. And that's typical with a disc bulge. Now, you can see any of these kind of in combination as well. You can have a disc bulge with what happens to kind of our next level, which is a disc tear that causes some of the inside to leak out, the jelly from the jelly donut. And so you can actually get these superimposed as well. And so, the disc tear itself is an injury to those fibers that one causes decreased stability. The disc is now less substantial or less integrated than it was before. So you can see increased motion, which then again can lead to some of these other things. And then over time, we see degenerative disc, where the area becomes thinner. And the key thing to kind of point out with more of the degenerative disc is that this whole system works in concert, the ligaments, the joints, the disc, and the vertebral bodies. So that if I make this space less, I get more pressure on the facets as well, which is essentially arthritis in the neck. And the ligaments that were stabilizing things are now looser, because instead of being a taut rope from point A to point B, it's now a loose rope still connecting those 2 points, even though there was no direct injury to the ligament itself. So now that these are looser, there's less posterior stability, which overstresses the front side of the system, which makes the disc disease worse. So it's really kind of this positive feedback or snowball effect where the symptoms can progress more rapidly over time. One of the reasons that we think earlier treatment yields better results. We look at pain in this kind of model in really 3 different ways. All of these, this is a kind of a pain wheel that we talk about of this neurochemical mechanical symptom of pain, meaning there can be a direct problem with the nerve, there can be an irritant that's upsetting the nerve, or there can be a mechanical stress, and they all then feed into each other. And you can see there's the kind of examples written for each of these, but I think a good example is really car accidents. So a neck injury from a car crash, this is a great study from the Journal of Pain, showing that it causes problems that are long lasting essentially. And so you can pick any part of the system. So one, whiplash injury, the head goes kind of forward and then back. In that forward span, we loosened up all of these ligaments, which is our mechanical part of it. And then as the ligaments are loose, like I talked about before, it overstresses the disc, which becomes degenerative with change, degenerative change with time. And then that stress may cause issues in the back, where now we're leaking some of that nucleus out, and we have a neural irritant. And then we see the symptoms that kind of come down typically into the arm or hand. So this system all kind of works together. It's one of the ways that we think about pain. It's one of the ways that we think about doing a good physical exam as well, which is different than what you might find from a orthopedic surgeon, pain management, sports medicine. We really kind of look at this whole system. One of the things that we look at as far as, well, where do our symptoms go? Where do we typically feel free from pain from these levels is a really nice pain map. And so what we're looking at here is pain distribution based off of level. So we talked about before how we kind of define those areas as we number each vertebrae. And the joints are a relationship of the vertebrae above and the vertebrae below. And we named the disc for the 2 vertebrae that they're between. So a C2-3 disc would be sitting between the second and third vertebrae of the spine. And the pain typically refers to pretty classic patterns. And so certainly your higher levels are higher up, our lower levels are lower down. But what's really interesting is when we get to these lower levels, we see more of a pain distribution around the shoulder blade. And so I very commonly have patients saying, hey, I've got shoulder blade pain, and I immediately go and look at their neck, because that's typically where it comes from. And it can be both the disc, it can also be the facet. And again, the physical exam can kind of define that a little bit more. You'll see that on the one where we're looking at the disc distribution level, our highest is that 2-3, which is the top disc that we have. There is no such thing as a C1-2 disc. There's no such thing as a C0-1 disc. But oftentimes when we look at the joint pattern, the higher levels are typically omitted. And there's a couple reasons for that. One is that it's a technically difficult procedure to actually inject at that level, something that all of us Regenexx docs are trained in. We do on a regular basis, but an average interventionalist pain management doc may not have done many of those, maybe a couple a year as opposed to a couple a week. And so this is an area that kind of gets neglected as a no man's land, but can really influence some of the pain that we're having. So when we look at these higher level areas, our 0-1, our 1-2, and even our 2-3 joints, these are areas that come up into the base of the skull. And oftentimes this is a typical headache referral pattern. At our 2-3 level, we have a couple of nerves that I think we're going to look at here in a minute. And we'll kind of talk about where these nerves come out. But 2-3 involves a very specific nerve, and 0-1, 1-2 can often cause these kind of posterior headache type symptoms. Like I said, the treatment is a little bit more difficult to get to that level. It requires fluoroscopy. Oftentimes it requires special software on that fluoroscopy to make sure that we get it done safely. And again, that's something that we do on a fairly regular basis. The muscles themselves can be treated. And so this is a classic kind of trigger point referral pattern, pain referral pattern, looking at all sorts of different muscles. And the point here is not really to kind of understand the specifics. That's my job. But my purpose of demonstration is to show you that you can have pain in one location, such as one of our big neck muscles, the sternocleidomastoid, and have symptoms that are on the front of the face or the top of the skull. And so these are areas that, again, the physical exam and getting a thorough history where we're looking for all of these things, not just saying, oh, you have a disc injury, you need an epidural, or your facets are irritated, we should block the nerves that go to that facet. And actually treating the underlying root cause is a big part of kind of what we do for our patients. This is a little bit of a complicated drawing, but we're only going to look at really three things here, three primary nerves that give us some trouble. So this is the back of the skull with a picture of a dissection down to the level of the muscles and where the nerves come out of the fascia. And we're going to look at really three primary nerves that become big players when we evaluate neck pain and headaches. And that's the greater occipital nerve, situated right here, comes up and over the top of the skull. The lesser occipital nerve down here, which does the same thing but tracks towards the temporal region of the skull. And then our third occipital nerve, which comes out between that level 2, 3 that I was talking about, and is often a big player in some of these posterior headaches. So third occipital nerve is going to give us these base of the skull headaches. Greater occipital is sometimes over the top or around the eyeball, and then the lesser occipital nerve more in the temporal region. And these can all be treated too. When we treat these regions, we're not using something like steroid, which can hurt. We're using a platelet product called platelet lysate, which is just used for growth factors to help kind of calm down the nerve and give some relief in areas where there's compression. Plus, by doing the injection itself under guidance, we actually open up the tunnel, the gap that these nerves come through as they go through the skin. So we take some of the impingement away and make the nerve kind of in a happier, healthier environment. We talk a little bit about steroid injections as well. There are obviously concerns with that. Our body naturally makes steroid in response to stress. And when you have a dose of steroid that you get from, again, like an epidural steroid injection, it's about 1 million times than what your body normally makes. So it's incredibly high level. And it does work temporarily. It stops our cells that are the ones that help produce inflammation and pain signals, but it doesn't do anything for the underlying cause. And we know from multiple studies that it really hurts collagen, which are the supporting structures of our joints, our disc, and our ligaments. We also see it affect other parts of the body unrelated to where the injection is. So loss of bone density. We know from one large study that up to about 30% increased risk in spinal fracture. And again, the big thing and kind of our perspective is that it's not treating the root cause. It's not treating the source of the problem, which we kind of talked about with the ligaments, the joints, and the disc. There are some other alternatives that are out there for kind of treating disc disease. And so the picture on the left just shows degenerative change throughout the disc with kind of this, cartoonified graph. So getting back to what we're talking about is some of the alternative treatments that are out there. This is an example of degenerative disc disease on the left, and you can see kind of an animated tear running through the side of it, with obviously the red denoting that it's painful and irritated, and showing kind of an artificial disc. So this is one of the things that's been kind of promoted as an alternative to spinal fusion surgery, using essentially a prosthesis for the disc, and they promote it as being more flexible and able to kind of preserve motion. One of the concerns with fusion is obviously by fusing the bones or having hardware running between two of these levels, you no longer have any motion. The only concern is that it doesn't actually turn out to do that. And so here's a CT of a patient that's had a cervical fusion, it's artificial disc replacement of their cervical spine, and it's between their 3, 4, 5, 6, so it's their 5, 6 level that you can see this kind of prosthesis representing the disc. The arrows on this left side of the picture are showing bone formation that's starting to overgrow the disc posteriorly, back where the spinal cord lives. And then on this is a frontal projection where we're looking from front to back. You can see the vertebral body at the level above, vertebral body at the level below, and bone has completely bridged that. So this is essentially a functional fusion because once the bone fuses from top to bottom, there's no longer motion at this level, which again is what this is typically promoted as being motion preserving. And it turns out when we study it, that's not the case. There's some data looking at kind of what our outcomes are, percentage of patients who develop what's called adjacent segment disease, or ASD. So what does that mean? If we use, again, this kind of schematic on the right-hand side, you can see hardware denoted in black, fusing two vertebral bodies. So the disc no longer moves. It doesn't matter if it's degenerated or not, because there's now no motion between this level. But what has to happen in order for you to do the stuff that you need to do, like looking up at a screen, looking down at your phone, increased motion occurs at the levels next to the fusion. And that's really what starts this development of adjacent segment disease, which is overloading the disc and overloading the joints on the back. And when we look at the percentage of patients that develop this with fusion as well as artificial disc replacement, you're seeing almost 80%. I think this is 78% is the actual data of patients that have fusion will develop adjacent segment disease. And then if you look at artificial disc replacement, it's still 1 in 2. It's just over 50%. So we still kind of see the same bad effects of this treatment on patients that have operative management. Here's an example of kind of one of our treatments. This was a patient that had a cervical spine bulge and herniation, so kind of a mixed picture that we talked about at the very beginning of the presentation. And so again, we're looking in the two pictures to the left, they're before and after views that are shot going from left to right. And so this is a disc level where, again, you can see kind of this bulge or pot belly kind of sticking off the back. It has kind of a mixed gray appearance to it, which tells me that some of that is also the intradiscal material that's been coming out in this area. And then this is a patient that was treated with stem cells, and we have resolution kind of at the level behind it. One of the things that we do often talk about is that there are some discs that will heal on their own. In this patient, they had a non-symptomatic disc bulge at a level higher. So if we just go up 2 levels above, you can see a disc bulge here that was not treated. And on follow-up exam, it's also unchanged. So again, this goes back to having a good physical exam, determining what is the primary pain generator, and then treating that appropriately. For many things in the cervical spine, we can get away with treating with just platelets. And so that can be platelets inside the joints, which are back here. It can be platelets into the ligaments as well to give some support to it. It can be platelets in the epidural space, which kind of lines where the nerves are. And the epidural space also contacts where the disc is. So when there's tears or bulges, we can make that strong. In some instances, we do have to use stem cell or concentrated bone marrow to inject these areas. And those can be done in the same areas, the ligaments, the facets, typically not in the epidural space, but we can also do it intradiscal, where, again, using precise image guidance, we get the biologic substance directly into the disc itself. And again, we're seeing outcomes here. This is a top-down or bottom-up picture. The right side's on the left side's on the right. You can see kind of the vertebral body. And then this is the spinal cord at this level, same on this picture. And you can see where the big bulge is. I would say that there's a little tear here, where we're seeing that herniation of disc material coming out from. And that, after kind of a single treatment, has closed back up. We no longer see the bulge going into the space where the spinal cord lives, and is starting to improve there. So again, our treatments can cover a lot of territory, treating directly the disc itself, but also treating the areas of pathology that kind of contribute to it. I think one of the things that's also interesting in this picture is how much the muscle has actually improved as well. So when we look at the changes here, the dark black is actual spine muscle, and the bright white is fat. And so from a little bit of nerve compression, these muscles are starting to turn off, but at 4 months, we're seeing some improvement where there's less of that white going through the muscles as well. So that kind of looks at what our basic treatments are for kind of the cervical spine, addressing both headaches as well as neck pain and symptoms that go down into the arm and the hand. If anyone has any questions, please feel free to write them down in the chat box. We'll go through those. I do have some questions that were pre-generated by webinar attendees, and so we'll kind of hit some of those and talk about that. But yes, please feel free to contribute and add any questions that you have. So now that we're back, so yes, so certainly feel free to add some questions in there. I'll read the ones that I have. So one of our questions was, had an MRI last year which shows usage wear on my upper spine. It's allowing the nerve to get pinched and causing right arm pain. Occasionally I lose use of my hand and fingers. So this is very common in what we call a cervical radiculopathy, meaning that the degenerative change is starting to compress the nerve and causing symptoms elsewhere in the body. And so this goes back to really the very beginning of our talk, which is that we need to treat the whole system. So we would want to treat certainly around the nerve, and that's kind of the epidural space that covers the nerve. We would typically use something like a platelet lysate for that. Again, that's platelets that have been broken or lysed, and we get just the growth factors out of them. We would want to treat the facets, because the facets kind of act like pillows on the backside of the spine. We can bolster those up, which generates more room for the nerve to get out of. And then we want to strengthen the ligaments because that too, one, can open up that space and also give some greater support. So there's less motion in that area that would allow for compression of that nerve. So really good question. Definitely demonstrates kind of exactly what we were talking about today. We had another question. I'm having pain in my neck, especially if I sit at a computer very long. I've had upper and lower back pain for years. Also some hip issues. So yeah, absolutely. You know, we all kind of develop this forward head carriage from us staring at computers all day, or again, looking down at our cell phones. And so over time, that makes our ligaments more loose. And so we see the damage of that under x-rays or MRI is involving either the disc or the joints, but really one of the most important things that we can treat is the ligaments. And that's something that's often missed by other interventionalists that treat cervical spine. So, you know, this would be a good case that certainly we should evaluate that and would likely have good outcomes for. I have had a couple of other questions. And so one is I'm just dealing with stiffness and I'm trying to stretch. And I really like this question because this is one of the things that I also see a lot of. So to address the sensation of tightness or the feeling like you need to stretch, or if you're a patient who kind of self-articulates their neck, meaning you kind of push on your chin to get a pop and then you get a relief of symptoms, this is almost certainly not the muscles that are causing you the trouble. It's an underlying symptom of the primary problem. And so that may be disc, it may be facet, but it's certainly instability. So what happens is as our ligaments become loose, our brain doesn't like to sit on a wobble. It wants to be kind of situated straight, eyes across the horizon. And so if the ligaments aren't doing their job, the muscles and tendons have to. So they pull much tighter, which gives us this sensation of tightness and feeling like we need to stretch. And so again, in patients that will self-articulate themselves, you get a reflex inhibition. So that pop tells some of those nerves that go to the muscles to relax for a period of time. But then the head's back on a wobble, the muscles tighten back up, and you develop those primary symptoms again. And so many of these patients will get trigger point injections to kind of calm down the muscles, but that's not, again, the root problem. It's only a symptom of the underlying problem, which is almost certainly instability. So that's a really good question and something that I see very, very commonly, and something that we have great success in treating. So as I go on, I see no questions in the chat bar. So thanks everyone for joining. And again, if you have any questions or have any areas of interest for future content, please feel free to email me. Otherwise, I will see you at our next lunchtime webinar. Take care. Bye.